Good morning, everybody. It's a great pleasure to have you here today and that you listen to us. EHA 2025 is over. We had some very, very interesting days in Milan. It was very hot, very sticky, but the talks and the atmosphere was great as usual. And I think from the MPN side, we can say that there have been many interesting presentations and many new things are going up. This is why it's a great pleasure for me today to have Haifa, Professor Haifa Al-Ali from University from Halle. And she has been there and she has been obviously attending all these meetings. And I have been requesting her to give us a little rundown for in a patient friendly language in order that we know what has been discussed and why can we be so positive for the future regarding the treatment of MPN. So Haifa, thank you very much for coming, and please, I give the micro to you, and just let me know what went on.
Yeah, good day to you, Peter. Good day to everybody. Thank you so much for inviting me. It's really a pleasure. As you said, Milan was really very, very busy, but it was an exciting time. I really liked it. There were almost 15,000 delegates attending the meeting. And one of the most important things I personally found very nice was the strong voice of patients. You know, in big symposia where hundreds of participants were listening, as well as face to face, but also virtually, patients were part of the faculty. They had their presentation. So the voice of the patient, particularly in the MPN scenario, was very, very strong. For example, we had one symposium where we discussed the different aspects of anemia. First, from the perspective of physicians, but most importantly as well, from the perspective of patients. And there was even a patient from the UK that, as a video, which showed all the symptom burden and the suffering of patients with MPN. She was a case of myelofibrosis and she was suffering as well from anemia, blood transfusions. And so we had actually 19 minutes of discussion about symptoms. But then what could we do? We know that there are a lot of new JAK inhibitors like momelotinib, which pacritinib in the United States, which could help making patients become transfusion independent, that they do not need blood transfusions anymore. They could improve the anemia and patients could feel better. And today we have realized that the improvement in the hemoglobin and particularly becoming blood transfusion independent is a very important aspect, not only from the quality of life, which is very, very important, but also for a longer survival. You know, just a few years ago, it was only bone marrow transplantation which could correct such anemia and blood transfusion. But today, we know that we could, in not all, but many patients, convert transfusion-dependent anemia into no anemia. As I said, quality of life and survival. But you know, still there is an unmet need. These drugs do not help everybody. So the question is combinations. And we discussed what could we combine, for example, with ruxolitinib, Jakavi, a very well-known JAK inhibitor, very good for symptoms and spleen, but not that good for anemia. And there are a lot of things coming soon. We have phase 3 clinical trials with luspatercept. This is a subcutaneous injection given every 3 weeks for anemic transfusion-dependent patients. And the data, we hope, will come soon at the upcoming EHA. And if the data are positive, then this combination, JAK inhibitor plus luspatercept, could be approved next year or maybe 2027 for patients with anemia and transfusion dependency. And there are many, many other combinations that are being evaluated, particularly for anemia. So I think the future is very bright, and what is going on is very, very promising. This is in terms of anemia and transfusion dependency regarding myelofibrosis. But again, there were very interesting aspects, particularly for patients with essential thrombocythemia. In the last 15 years, we had a lot of drugs coming up for myelofibrosis, the JAK inhibitors. We had then new drugs coming up for polycythemia vera, like the pegylated ropec interferon known as Besremi. We have ruxolitinib, the JAK inhibitor, Jakavi, a second-line option for patients with polycythemia vera. And there was a lot, research, publications, awareness about the symptoms and how to improve the blood counts, how to reduce thrombotic events in patients with PV and also myelofibrosis. But there was nothing much for patients with essential thrombocythemia. And we know also that essential thrombocythemia is a disease that has a good prognosis, but many, many patients have the same symptoms, the same problems like patients with polycythemia vera or patients with myelofibrosis in terms of, for example, fatigue, pruritus, and social problems, health insurance problems, work problems. But, nobody really cared that much because there were no new drugs and no new developments. And we had this classical hydroxyurea, which we know for decades, and anagrelide, which is just a drug to reduce the platelet counts, but we didn't have much. We all, physicians, particularly in younger patients, patients who wanted to get pregnant, used off-label interferon. But at this EHA, we had two very, very important new data to essential thrombocythemia. Actually, one was presented in the plenary session. This is the main session where the best abstracts are presented, usually 5. And the second presentation was in the late breaking abstract, which is again a highlight session of every Congress where the newest developments, and only 5 again, will be presented. And 2 at the plenary one and 1 at the late breaking session were dealing with new developments in patients with essential thrombocythemia. In the plenary session, the data of a clinical trial in patients with essential thrombocythemia who fail standard treatment with hydroxyurea was presented when these patients were then treated with either ropec interferon, the pegylated interferon we know from polycythemia vera, Besremi, versus the traditional anagrelide. And as is expected, the results were very, very positive in terms of control of blood values, in terms of improvement in symptoms. I criticized one point in this trial that they tried very rapidly to increase the dose of Besremi within the first 4 weeks, reaching even up to 500 micrograms. And this, I think, led to more adverse events because we know very well in polycythemia vera, we increase the dose of Besremi slowly, so the tolerability and patients could stay for a long time on the drug. But overall, I think that the data of this trial are very promising, and I would expect that these data will lead to the approval of the pegylated interferon Besremi in the second line setting in patients with essential thrombocythemia. The second very interesting development was actually in the late-breaking abstract. All our treatments we are using today, they all aim at not cure, They try to induce remissions, make patients feel better, less complications. We always speak about the so-called disease modification, although we don't know what this means. But, at the end of the day, cure is not yet possible. And I think we don't need cure, to be honest. We have to chronify, make these diseases chronic. I always say aging, we don't want to treat aging, and we could live well with this. And this is the idea. And I think we have a good way done in PV, in myelofibrosis. And for ET, but there is the option that this time there is an antibody as an infusion that is given to patients with essential thrombocythemia or myelofibrosis that carry the calreticulin mutation, which we know is present in about 25% of patients with ET or myelofibrosis. And this antibody works directly against this mutated calreticulin because the calreticulin mutation can be expressed on the surface of cells. So the medication can recognize this cell which carries the mutated calreticulin and kill only this stem cell. So we are actually using immunology to attack the disease. And in animal models, in cell cultures, this infusion has already shown that sick stem cells are killed and the normal stem cells can again proliferate. So the idea is going against the cause of the disease. And the phase 1 data for a group of patients treated in 2 clinical trials, one in the United States and one in Europe, Japan, Canada, and Australia, were presented where 41 patients with ET, I said this trial is for ET and myelofibrosis, but the data were presented for ET, and these 41 patients that were treated with this calreticulin, mutated calreticulin antibody that is given as an infusion every 2 weeks was presented. On the bottom line, the infusion, I have this trial, I have many patients, is a beautiful thing for patients. It doesn't have toxicities. There was not one single thrombocytopenia until now. It is a phase 1. That means we are dose escalating in this trial. Just for you, we started with 10 milligram, and at the present time, we are evaluating the 4,500 milligram of this infusion every 2 weeks, and no patient is having a dose-limiting toxicity. And patients feel very rapidly, very well. We had complete remissions, normalization of the blood counts, of the platelets in 2/3 of patients within a very short time. And still the data are very new, but also the allele burden of this mutated calreticulin dropped in the majority of patients very rapidly. So this is really very exciting, very promising. And my expectation is if these trials go very well, within 2 years, let's say 2, maximum 3 years, we might have a treatment with a potential cure for 25% of patients with essential thrombocythemia and myelofibrosis that carry this mutated calreticulin. This is great. But still, 2/3 of our patients have the JAK2 mutation. There was nothing explicit like the antibody for JAK2 mutations, but I can promise that in the beginning of next year and maybe the end of this year, there will be clinical trials starting with specific JAK2 mutation oral therapies. So the development is really very, very promising. And as I said, we aim at improving the quality of life, which is still very, very, very important. We want to improve survival. And now we are speaking even about the potential of curing these diseases in the near future.
Thank you very much. I like, what you're saying, that the important thing is that we can find a chronification. This is what I'm, since many years, I'm battling for this. It's not so much about you cure, but, like you have it in CML and other in blood diseases, you have a chronification. And I think this is what we should go on. Now, this new treatment for ET, is that a sort of a vaccine? Is that what has been talked in the past? That we are working on a vaccine for ET? Is what
Not actually a vaccination. It is, as I said, an infusion. But
it's
the idea
infusion.
is similar. Infusion given, apparent IV
Yeah.
intravenously, but it is, the idea is the same. Like, well, in a vaccination, you ask your own body to make antibodies against
Antibody, yeah.
something. But here we are giving the antibody directly to the patient.
Okay.
But the next step, and again, there is this development that we will combine this antibody with certain, like the bispecific antibodies. So they will be not only the antibody, what we will stimulate the own immune cells, the so-called lymphocytes of the own body, to fight together. This is called bispecific antibodies. And again, for this mutant calreticulin antibody, there is such a bispecific antibody that is in development and will soon enter into clinical trials. So we are using our own immune system to fight the disease.
Okay. Well, thank you very much for this explanation. We had agreed that we make it short today. The problem is when I start to talk to you, I could talk for an hour because you are a Biblery, about all these questions, and we have so many questions. But let's keep it short today. I think this was a very, very excellent report about main points from EHA. I think we can be very positive. We can look in a positive future. New things are happening. So many people is working on improving our quality of life, not only on the researcher side, but as I told you before, also on the pharmaceutical side. We have big advances in order that the patient voice is coming to the right people, and but I can explain how much we are suffering on the different quality of life issues, like you have mentioned, anemia, transfusion dependence, etc., etc. So thank you very much for this early morning talk. I wish you a great day. Have a good weekend, and thank you very much. And I'm sure we will talk hopefully soon as possible, or probably after summer holidays, in order we can continue our conversations. Thank you very much.
Thank you very much, and all the best to all of you. Thank you.
Thank you. Okay, have a good day. Yeah.